All right. Hi, welcome to the webinar, What to Know About Ovarian Cancer Recurrence. I'm Maggie Nicholas Alexander, the Ovarian Cancer Program Director at SHARE. Before the presentation begins, I'd like to tell you a little bit about SHARE. SHARE is a nonprofit organization that has been helping people through breast, metastatic breast, ovarian, and uterine cancer for the last 45 years by offering the support of those who have been there. SHARE provides many services, including a helpline, support groups, and educational programs. All services are free of charge to participants. For more information, please visit our website at sharecancersupport.org. All participants will be muted during the presentation. When Dr. Wethington finishes presenting, we will begin the Q&A discussion. You are welcome to submit questions during the presentation through the Q&A section at the bottom of your screen. When asking questions, remember that Dr. Wethington is unable to give specific medical advice. So please keep your questions general in nature. This webinar is being recorded and will be available on the SHARE website soon. Now I'd like to say a few words about the significance of today's program. I'm just going to share my screen. Oh. Okay, it's not working. But basically, this is SHARE's 7th annual Joan Summer Educational Program. And this program today is in honor of her. Joan was a nurse diagnosed with stage 4 ovarian cancer at the birth of her 3rd child. She lived with ovarian cancer for 22 years. With her natural wry humor and intelligence, Joan and her family inspired and supported the SHARE community. The summer legacy continues, and we're so happy to have today's program in her honor. Now I'd like to introduce our speaker for today. Dr. Stephanie Wethington is a board-certified gynecologic oncologist who treats patients with a range of gynecologic cancers, including uterine, cervical, vulvar, vaginal, and ovarian cancer, as well as gestational trophoblastic disease. She is an assistant professor in the Kelly Gynecologic Oncology Service of the Johns Hopkins Department of Gynecology and Obstetrics. Dr. Wethington has a particular interest in cancer survivorship and leads the Susan L. Burgert M.D. Gynecologic Oncology Survivorship Program, which is a program that addresses the unmet needs of gynecologic oncology patients and their caregivers. And we're so happy to have her here today to give this presentation. So I'll turn it over to you now, Dr. Wethington.
Thank you very, very much. I appreciate being here. I was saying when we were in the pre-room together that doing these talks is actually my favorite thing to do. There's nothing that I actually enjoy more and sort of reminds me best of why I do what I do. So thank you very much for having me here today. And I am going to now share my screen and we'll get started. Okay, here we go. Hopefully all is going to go as it should. Maggie, if my screen isn't quite right, let me know. But sort of good. Okay, good. What I'm going to do today is sort of provide a framework. And I think of that framework as something I call charting your path. And one of my goals is to provide a framework in which to plug in your own individual experience. We all have common experiences when we're facing an ovarian cancer diagnosis or an ovarian cancer recurrence, and then there are unique things about each individual. So what I hope you'll find as you listen is that there are points of connection where I see something that resonates, and there are points of difference actually where your unique journey or the unique aspects of your cancer or your family or your personal preferences, you notice differences, because that's sort of what adds to the robustness and the richness of what we're talking about today. So I'm going to sort of go over charting your path. I don't have any financial disclosures, nothing that I'm going to discuss in any way. Is there a financial conflict of interest? But I do have always in every talk I give when I talk to survivors, a conflict of interest in the sense that I bring to these talks, and I hope everyone will walk away with a sense of hope. And that's sort of the vision that I want to convey, and the spirit that I want to convey in what I'm talking about. And hope comes in many different forms. One of the things through our survivorship program that we're able to do is actually host a weekend retreat for individuals with gynecologic cancer and their caregivers, sometimes a spouse, sometimes a family member, different relationships. But it's a weekend retreat that's really geared around the conversations of resilience and hope and what this means. And what I show on the screen here is, I think in the center, what some of us think of when we think of hope, sort of a big, broad, expansive feeling. And then on either side at our most recent retreat, some of what folks brought up about hope and some of what they think of when they think of what hope means. And I love the line on the left lower that's underlined. Hope implies that the future is open. And so a lot of what we're going to be talking about is the opening of doors and the opening of opportunities today. And so as we go through, get out your pens, take some notes, think of your questions for Maggie, and think about what opportunities we're mentioning for the future for you today. So a little bit about ovarian cancer 101. You know, we talk about ovarian cancer, and oftentimes all of us who are in the ovarian cancer world, when we give talks on ovarian cancer, we sort of fall into some patterns where often we're talking about the high-grade serous epithelial ovarian cancers. There are three big categories of ovarian cancers: epithelial, sex cord stromal, and germ cell. And the epithelial are the most common. The serous are the most common of those. And so by nature, often the conversations focus on serous, high grade in particular. And I'm going to try really hard to balance it out and talk about some of the other cancer types as we walk through. I apologize in advance. It should be sort of my third disclosure that it is about nothing other than sheer numbers, that sometimes it's not as balanced with the other cell types, that we have this tendency to focus more on the serous. I also put ovarian in quotation marks because certainly germ cell and sex cord stromal tumors arise in the ovary itself from particular cellular components of the ovary. But now that we've gained more information and more molecular understanding, we actually have come to identify that many/most/ maybe even all of the high-grade serous ovarian cancers actually arise originally in the fallopian tube in a lesion that we call a STIC, or a tubal intraepithelial carcinoma. And that then spreads. Those fallopian tube cells are loose. The fallopian tube is open. It has fingers on the end, the fimbria, and it helps disseminate these cells that land on the ovary or land on the peritoneum. So the other sort of bias or disclosure in my language that I use is when I say ovary, I actually mean ovary, fallopian tube, and peritoneum. When it comes to these cancers. If I said that every time, we'd be here for well over the hour that we have allotted. So your patience with that as well. So if we're going to sort of embrace that bias of the most common of the ovarian cancers, this high-grade serous epithelial ovarian cancer, we've really in the last decade come to understand a lot about the pathophysiology of it, where it comes from, what are the mutations or abnormalities in the tumors that drive the tumors, how often are those inherited elements, things like the BRCA mutations or the Lynch syndrome mutations that we know pass on a higher risk of developing these cancers within families. as well as the potential for a tumor to have these mutations not inherited, but within the tumor, something we call a somatic mutation, a mutation that's found in the tumor, but not in the rest of the body. And so we've really come in the last decade to subdivide, even amongst our serous epithelials, into tumors that have a homologous recombination deficiency. That's the fancy term related to these BRCA mutations. It's a molecular type, and the homologous recombination proficient. And so these sort of distinctions, our categorizations are actually moving beyond categorizations of histology, what it looks like under the microscope. And those terms are things like serous, mucinous, endometrioid, clear cell, granulosa cell, yolk sac, germ cell, these sort of histology or pathology findings. And we're now incorporating into our conversations molecular markers or molecular terminology, molecular categorizations, presence or absence of BRCA mutations in the germline, presence or absence of BRCA mutations in the tumor, HRD, and there's some assays to test for HRD that are not related to the mutations, but other functional abnormalities within the tumors. And for instance, in the granulosa cell tumors, we've now found that many or most of those have FOXL2 mutations. So we're expanding beyond just the serous ovarian cancers into many of our types to understand these molecular underpinnings, ARID1A mutations in endometrioid. And so we're adding a new categorization having to do with the molecular subtypes. And we are hoping and working towards being able to target some of our treatments to these molecular subtypes. The one that we are able to do this best for thus far are our serous tumors. So what is a cancer recurrence? You know, I often get this question from patients, and it's a really good question. You had surgery. We took out the ovaries. We took out the fallopian tubes. We took out the uterus. We took out all the areas where there was cancer at the start. So then what is a cancer recurrence, and how does that happen? Well, that comes back to sort of what is the fundamental definition of what is a cancer, as opposed to just a mass or a tumor. And a cancer is really a disease in which the cells grow uncontrollably. And by definition, if something reaches the mark of being a cancer, it has the potential to grow elsewhere in the body, a place other than where it started from. And it has the potential to spread and to hide a little bit in dormancy or in remission, and then recur and come back later. So a cancer recurrence in the setting of an ovarian cancer is that coming back and being visible again. And maybe, as you see in these pictures, the lower right, it's visible in the liver, or in the upper, visible in the brain, or visible in the abdomen and pelvis, in the peritoneum or the omentum, which is what you see in that middlemost picture. So a cancer recurrence is really when the cancer cells begin to grow again after initial treatment somewhere else in the body other than where they started from, most commonly, because most commonly for most cancers, we've removed the primary at the beginning of treatment. There are a few exceptions if you fall into that category of folks who have a germ cell or a sex cord stromal tumor and were very young when you were diagnosed. Perhaps you actually do have the other ovary in some situations. So it is possible that it would come back on the other ovary, for instance. So when we talk about categorizing ovarian cancer recurrences, when we talk about the epithelial cancers in particular, but really any, we categorize by duration of time from completion of initial therapy. And we talk about this in the context of response to future lines of therapy. And we've come up with some definitions based on these responses. So we talk about tumors that are platinum sensitive. That means that the cancer returned in more than 6 months. Platinum resistant, it means the cancer came back in less than 6 months. Or platinum refractory, and that means it actually grew while on that initial therapy. These categories help us in terms of thinking about our treatments and what treatments we're going to use in the recurrent setting. And so when we talk about our treatment options, we can actually sort of provide some labels or some categories. And we can talk about things in terms of whether they are a standard of care either because they've been FDA approved or because they have NCCN compendia listing. The NCCN is a group of 40 some institutions now. I think it's 42, but don't quote me on that. 40 some institutions that come together to set some guidelines. It's what Medicare and Medicaid use to determine what treatments they're going to fund under those insurance mechanisms. So standards of care, things that are accepted, that have solid data behind them, and then clinical trials, things that are in study still. So this is one way to label your treatment options. And another label is to put on the category of what kind of treatment is it? Is it a surgery? Is it radiation? Is it a systemic therapy? And gosh, nowadays, thank goodness, we have a lot of systemic therapy options. So when we talk about systemic therapy, we can be talking about the traditional cytotoxic chemotherapies, carboplatin, paclitaxel, bleomycin, etoposide, things that we've used now for many, many years. We can talk about targeted agents, some of our newer drugs like Avastin, for instance, hormonal therapies, low-grade serous ovarian cancers, super responsive to hormonal therapies, which because of some great work in the past decade have been sort of re-emphasized for certain tumor types within ovarian cancer, low-grade serous being a primary one, for instance, and the immunotherapies. So our systemic therapies come in a variety of different formulations and different mechanisms of action. And so we can start to put our treatments together and take our categories of the recurrence, platinum sensitive, platinum resistant, and platinum refractory, and then think about what are within that our categories of treatments that are options. So really our surgical intervention for the purpose of treating the cancer as opposed to treating a symptom of the cancer, our surgical interventions are really in the platinum sensitive setting. Radiation can fall across all three and really is location of tumor dependent, something we use much more commonly when a tumor is located or a cancer, area of cancer is located in the brain or the bone, for instance. Systemic therapies, and that's again, all of our systemic therapies and clinical trials. And I put this out there right from the start. Clinical trials can be a good option for people, no matter what the recurrent setting, or even in the upfront setting sometimes. So clinical trials fall across all settings and categories of disease. And we're going to talk more about clinical trials as we continue our talk. So the other thing I want to focus on is I really focus sort of on what we typically think of our treatments just now, right? Surgery, chemo, radiation, targeted therapies. But I want to expand this definition a little bit when we think about what our treatments are. And I want to expand it to include what I consider to be the full range of treatment options. And so I include in that nutrition, exercise, or movement. And I actually need to update my slide here and change exercise to movement, because I think our language around this should really focus on the fact that movement, whatever form it takes based on your individual limitations or abilities, is important. And so even if you can't, go out and run around the block, but you can do movement within your home, walk around your dining room table, do stretches, do yoga, do Tai Chi, anything, even stretches within a seat if you're not able to get up and walk around. All of these are very important. So I use this term of exercise or movement very broadly. Our expanded treatment team can include the intimacy of relationships with our family members and our support networks, our caregivers, our friends and family, other cancer survivors. It includes our primary care physician and making sure that even when we're undergoing treatment for our cancer, we're optimizing management of our underlying medical conditions, our high blood pressure, our diabetes, our thyroid, anything that we may have been addressing prior to diagnosis or that comes during our treatments. Palliative medicine, clergy members, either through the hospital or through our personal lives, clergy members that we have longtime relationships with prior to diagnosis or new relationships with, the social workers who help us, psychiatrists, psychologists, and our integrative medicine teams that could be providing as part of our treatments, massage, acupuncture, and in some cases, medications. And I put this in there and I very specifically call any drugs or anything we take that's provided by an integrative medicine physician as a medication for a very specific reason. All of these things can be helpful. All of them can have side effects. And so we need to be sure that we consider them a medication that we report and talk to our oncologists about, so that we can make sure that there are no interactions. So certainly many individuals are using things like turmeric or mistletoe or vitamin C, and it is vitally, vitally, vitally important that this is with full disclosure and conversation so that everything can be done safely. We think of them as vitamins, we think of them as nutrients, we think of them as natural, but they can have impact on our body that makes them something I would like us to consider more on the level of a medication, something that could have an interaction. So for safety reasons, I elevate them. I also add that these are areas of ongoing research and exploration where we don't have full data. So I can't yet comment, and none of us can really comment on their full impact, importance, or outcomes, although we are in the data gathering phase. And certainly mistletoe, for instance, is something that we at Hopkins have been studying. So I expand our treatment team really beyond a focus just on the cancer-directed therapies and expand it to be on the full body, head down to our toes, and everything in between. So our caregivers, critical member of our team. And if there are any caregivers on this call, I want to especially thank you for joining today. I hope the information that I'm sharing is helpful for you, but I also want to take one brief moment to emphasize the importance that you take care of yourself first and foremost, actually, before you take care of the person in your life who has the gynecologic cancer. You can't help anybody else unless you yourself are in good health. Ask lots of questions, identify resources, seek information, and there's lots of new opportunities and growing opportunities for caregivers, and then also seek the help of family and friends. So caregivers are a critical member of the treatment team. And then just a moment to emphasize caregivers, we also need to make sure that you are taken care of throughout this process and that is part of the treatment plan. That's part of sustainability in all of this for sure. I also mentioned palliative medicine, and a lot of times I get questions about palliative medicine. So I've preempted the question by including it, and I want to address that palliative medicine is a medical specialty. They provide a certain care and a philosophy of care. It's really geared towards your needs as the patient and not the cancer diagnosis or the cancer prognosis. It includes all the different elements of physical, psychological, and spiritual support and need, and really is geared towards addressing the symptoms and stress of cancer. And I have some of these key symptoms that they are most skilled at addressing, but certainly it extends beyond this. Things like pain, nausea, vomiting, constipation, anxiety, depression, difficulty breathing, appetite issues, fatigue, trouble sleeping, all these things that are very common for patients. And I think they also, many of us say, well, my oncologist addresses all these things. It is true. But I can acknowledge a limitation of, as an oncologist, I don't necessarily have all the time that these require. And sometimes actually those palliative medicine team members who I work with have some really good ideas and they look at things with a slightly different lens. And so it can be very helpful to get an independent set of inputs, just like your primary care will provide input on your high blood pressure and your diabetes. To have the palliative medicine team provide input can be very helpful. And this has been shown sort of again and again in a growing number of studies. Here, I give you just a brief visual of one of the first studies that looked at the early integration of palliative care into standard oncology care for folks with lung cancer. This is not done in GYN cancers. And you don't have to know anything about statistics to know that things improved when you introduced early palliative care. And on that right, if you just glance at that right graph, the higher line is actually survival. And so there is some data that supports that managing all those symptoms and including palliative medicine early in the recurrent setting can help really with a variety of things and have really good impact. So I think we're all a little hesitant and I want to dispel some of the myths and encourage folks, especially if you're having symptoms that aren't well controlled, to ask about this. And some oncologists have advanced training in palliative medicine and are able to do it themselves. And in some settings, it's a separate specialty. So let's go through some of our treatment options. Surgery. So these graphs are all about surgery for recurrence for serous cancer. I want to add one thing that the graphs for surgery for recurrence of a granulosa cell tumor, for instance, look even more impressive than this. So when we talk about surgery for recurrence in the granulosa cell tumor setting, it's very common. I don't know if we have any granulosa cell any women who have had granulosa cell tumors on the call today. But certainly, in some cases, patients with granulosa cell tumors can have 2, 3, 4, 5, 6, 7 surgeries. We just keep going in and taking out those tumors when they recur as often as necessary and as many times as is feasible and safe. In the setting of high-grade epithelial ovarian cancer, which is what this graph is about, we have a number of randomized trials that have come out in the last 3 years, and all based on initial retrospective data, which is what that upper left graph is. That's the initial retrospective data that made us ask the question, should we be taking folks who have recurrent cancer to the OR for a surgical procedure? And we've had a number of studies that have come out that have indicated that the most important element of this is patient selection. And that is doctor speak for making sure we're operating on the patients who are going to benefit. So always a good idea to ask the question, am I someone who's going to benefit from surgery? For the patients who are going to most benefit, there can be, for the properly chosen patient, there can be benefit, but not for everybody. So you may or may not find this to be part of your treatment plan in the recurrent setting. Radiation, I mentioned, is a brilliant treatment method for many types of ovarian cancer, most often geared towards brain, bone, and symptomatic areas of the body. Not used, sometimes I get the question, well, why can't you just radiate my whole abdomen and pelvis? We wish we could, but that would cause a lot of side effects and a lot of bowel issues. And so we don't just radiate globally, we radiate specifically particular lesions. And so it is a modality that can be used for isolated or specific locations. Really, the big area is systemic therapies. And we have had a number of FDA approvals in ovarian cancer. In this graph on the left, I really like, you notice that I start, and it's small spaces between 60 and 70 and 70 and 80 and 80 and 90 and 90 and 2000 and 2000 and 2010 is a tight space, but there's only one thing in there. And then between 2010 and 2020, we have as many dashes coming up and down as we do in the whole segment before. And what we've seen in the last 10 years is really an explosion of options for systemic therapy and actual FDA approvals in ovarian cancer. For a long time, we were limited to a small number of treatments, and now we have available to us many more. And the graph on the right is that NCCN listing of what is appropriate in different recurrent settings. And as you can see, there's a lot of things on that list, which is really nice. So let's talk about some of them and how they work a little bit. So cytotoxic chemotherapy, I call it cytotoxic because it kills cells. And all of these drugs somehow get themselves into the DNA replication process and mess it up so it doesn't happen properly. And the cell replication process is what I meant. And so here you have sort of a list of a lot of our common drugs and how that interruption works and what's going on, whether it's actually in the DNA synthesis itself, whether it's in the repair checkpoints that happen throughout the cell cycle, or whether it's in microtubule spindle assembly, which you see all the way on the right there. So a number of different mechanisms, all of which revolve around sort of killing the cells in their replication process. We also have seen introduction of VEGF inhibitors. Well, VEGF is vascular. So the V stands for vascular endothelial and growth factor, and it stimulates blood vessel development. And tumors, cancers need blood flow. They need blood flow because it's where they get their energy, it's where they get their nutrients, it's how they grow. So tumors by definition increase the blood flow to their area so that they can help themselves grow. And if we block that and we don't allow them to make new blood vessels, we don't allow them to grow, and therefore we decrease the tumors. And so that's kind of the theory behind our VEGF inhibitors. The most common one that we hear of or think about is Avastin or bevacizumab. Bevacizumab, now there are a number of generic or bioequivalents. So there sometimes different words used, but bevacizumab is sort of the core name that's similar amongst all of them. And it's an IV infusion. It can be given every 2 or 3 weeks, depending on how you're using it. And it is very commonly used in ovarian cancer, particularly in the recurrent setting, paired with other chemotherapies. So our VEGF inhibitors, very commonly one of our systemic therapies that we use. Now, PARP inhibitors. PARP inhibitors have been the practice changing, paradigm shifting revolution of the last 10 years. Really remarkable entities. And PARP inhibitors play on that homologous recombination deficiency that I mentioned earlier on, that category of dividing up ovarian cancer sort of into their molecular mechanisms slide that we started with. So DNA. The body does not want to replicate erroneous cells. It wants to do anything it possibly can to make sure that as cells replicate, the DNA is perfect. And so there are different mechanisms or repair mechanisms in place. Some of them can, remember the double helix from our biology classes, right? So in some settings, you can have a break in one of the strands of the double helix. In some cases, you can have double-stranded breaks. So there are different mechanisms of repair for single-stranded breaks and double-stranded breaks. You can insert things into the DNA and make it rigid so it won't move the way it's supposed to. You can create errors there can be errors in how the bases are matched to each other. And so there's mismatch repair. That's something that we talk about a lot with Lynch syndrome. But that the double-stranded DNA breaks are that homologous recombination repair process. It is probably one of the most, if not the most elegant and high fidelity, meaning highly accurate. Nothing's ever perfect, but as close as you can come to perfect kind of repair mechanism. And so when there is an error and that double-stranded DNA repair, that homologous recombination repair mechanism doesn't work, then cells become abnormal. And so that's sort of the underlying mechanism that we have. Well, PARP inhibitors take out the single-stranded DNA repair mechanisms. So if you have a BRCA mutation or a homologous recombination error that doesn't allow for double-stranded repair, and you have a single-stranded repair break, your single-stranded repair breaks will become double-stranded repair breaks. And then the cells, and without the ability to repair it, the cells will enter into apoptosis or cell death. And so it's a little bit of a two-hit, double-hit hypothesis or double-hit mechanism, whereby PARP inhibition is able to knock the cells into an apoptosis or cell death process. And that is why that homologous recombination mechanism or component is very important in the efficacy of PARP inhibitors. And for us in GYN cancers, I would argue this is the first time that we were able to take the biology of what was going on in the tumor, that BRCA mutation, either germline or somatic or HRD, and target it with a therapy that further disrupted the process and leads to cell death. So a great success to all of the scientists and clinicians who moved this forward in the lab for us. And what we found is that this theory behind why it should work related to errors in DNA repair translated into actual outcomes that we see in terms of progression-free survival benefits for, in some cases, all patients across all settings. And then, the benefits increase quite substantially the more HRD a tumor is. And that's what these graphs represent. You don't have to know your statistics. All you need to know is sort of looking at it. The top line are those PARP inhibitor lines, the bottom red line are the no PARP inhibitor lines. And you can see that there's a big gap between there. And really, when we are doing our research, these are the gaps that we are looking for in terms of improving outcomes. So immunotherapy, another avenue of still really in the research setting, but another avenue that we continue to explore in ovarian cancer is immunotherapy. It can come in a number of different forms. CAR T cell therapy is one. In this setting, we sort of prime we take the patient's blood, we take out the T cells, we sort of prime them and then reinsert these modified T cells to fight the cancer. And so that's the CAR T cell therapy. It's sort of using the own body's T cells and immune mechanisms to prime and activate. We can use checkpoint inhibitors, and the theory behind the checkpoint inhibitors is that there are checkpoints. There are moments at which the tumor cells find ways to hide from the natural T cells in the body. And this hiding mechanism is actually really important for tumors evading our own natural immune systems. And so checkpoint inhibitors take away the ability of the tumor to hide from our own immune system. And in that way, it revs up our immune system to fight the cancer. And so these are another one. You may have heard of particular pembrolizumab is very commonly mentioned. Nivolumab is another one in gynecologic cancers that's commonly mentioned. And these are still, I would say, also just like the CAR T cell therapy, more investigational. We haven't quite hit the right point with these agents in ovarian cancer, but we're trying. And so these are ongoing. And then vaccines. And we all right now, I think everybody knows about vaccines. I don't need to explain vaccine mechanisms. If anybody's turned the TV on recently, having nothing to do with ovarian cancer, you've heard about how vaccines stimulate the body's immune system to target. And so in the case of cancers, what the most important element specific for ovarian cancer, but true for all cancers, is finding the right target. What is the protein that we're going to target? Or the antigen, that's another word for it. What's the antigen that we're going to target to kill the tumor cells? And so there's been a lot of work aimed at developing an ovarian cancer vaccine. New York ESO1, for instance, is one of the targets that's been most extensively studied. And Dr. Dunsee's done some amazing work on this throughout his career. And then there are some newer vaccines that are coming about and are currently under investigation. And we all sort of continue to hope that one of these will be the next PARP inhibitor, right? We need a next PARP inhibitor. So vaccines, sort of not yet fully formulated, but under investigation and holding some promise. So antibody drug conjugates, ADCs, are another area that we're investigating. So what has been found is that this is one example, probably the most well-developed example right now that we're looking at. What we found is that the tumor cells will have certain receptors, in this case, the folate receptor alpha, that gets overexpressed, or there's an overexuberance of it on the tumor cells. And it allows for then a target. And what you can do is target that folate receptor. The folate receptor will actually involute in a drug that is then, or a substance that can then be released into the cell. So it's a more targeted release as opposed to general release in the system. And so one example of this that's currently under investigation with new data forthcoming with before the end of the year, we are all hopeful, is the mirvetuximab, which is one example. Fartuzumab, and I'm always struggle with these names, is another example of a folate receptor alpha target that's under investigation. So the folate receptor alpha, as well as antibody drug conjugates, with this being one example of an antibody drug conjugate targeting the folate receptor alpha, is another area of investigation and a thought and an idea of how we can get the drug to the cell that needs the drug and not as much in the systemic circulation. So this holds a lot of promise and one would hope might be one of our next PARP inhibitors. So what about combinations? So one of the big areas of clinical investigation right now is combinations, taking all these different things that I've talked about and putting them together in different combinations in order to elicit improved response. And here I have a nice table from a recent article that was looking at what are some of the combinations that are up and coming in study and under investigation. And all of these stem from a PARP inhibitor plus something else. So the PARP inhibitor is the base, but certainly there are other combinations of immunotherapies being investigated, for instance. But this is one example of, can we take PARP inhibitors and improve the efficacy of the PARP inhibitor, or expand the efficacy of the PARP inhibitor for the homologous recombination proficient tumors to improve response by adding something to it. And this is just a list of some of the different agents that are under investigation. Can we combine PARP inhibitor with a VEGF inhibitor, like for instance has been investigated with olaparib and cediranib, work by Joyce Liu up in Boston that's been ongoing for a long time, for instance. Can we mix our PARP inhibitor with immunotherapy? Can we mix our PARP inhibitor with chemotherapy? Can we mix our PARP inhibitor with other agents that affect the replication process, such as ATR inhibitors, CHEK1 inhibitors, WEE1 inhibitors, or topoisomerase inhibitors? So we've got a number of different combinations that are under investigation. So what are things under investigation? As I mentioned, these are clinical trials, and clinical trials are designed to answer a question. They answer different questions depending on which phase of the trial trial. So phase 1 really is looking at, in its simplest form, phase 1 is looking at safety, phase 2 at efficacy, phase 3 is a comparator type of study. So is this new regimen better than an older regimen, or is it equivalent with just a different side effect profile that may be more desirable? And then phase 4 is post-market surveillance. So clinical trials are designed to answer a question. They aren't yet the standard of care, and they have specific questions designed on their phase, depending on their phase. And as a patient, when you look at clinical trials, different clinical trials are available in different moments, and these change rapidly. But you may be interested in a different type of clinical trial depending on where in your disease course or what the availability is. But this is sort of a basic structure of what the clinical trials are looking at and how to think about them. So where do you find a clinical trial? Like, let's say you're a patient and you're wondering, well, you know what, I've recently, this is sort of how I often frame it. You want to think about, am I eligible for a clinical trial when there's going to be a change in therapy? If you're on a therapy and it's working for you, you don't want to change. You don't want to go looking for a clinical trial in that moment. But if you get a scan that says things are changing and your doctor says we're going to change our regimen, this is the moment, no matter where it is, early in the process, middle of the process, late in the process, to always ask the question, is this an appropriate moment for me to think about a clinical trial? What are the available clinical trials? And I looked last night to do a quick search as to whether or not there were, how many ovarian cancer clinical trials there are right now. I limited my search to the number of clinical trials that were open and recruiting. When you limit your search in that way, right now, there's over 600 clinical trials. That is a lot of clinical trials. You can further refine on clinicaltrials.gov, which is one website, some of the parameters. So what phase the trial is, where the trial is located, for instance, and also some more details about the types: serous, granulosa cell, germ cell, low grade, high grade, endometrioid, different components of the tumor. So that's one way to find a trial, in addition to asking your doctor, is now an appropriate moment, and seeing what's at your own institution. I'll also put in a little bit of a plug here. There are clinical trial matching services, and one of them actually is hosted by Share. These are extremely valuable, particularly if you ask at your own institution, is this a good moment for a clinical trial? Do you have one for me? And your doctor says, well, yes, it's a good moment, but unfortunately, we don't have anything that fits for you. This might be an opportunity for you to take a quick glance at clinicaltrials.gov, see what's there, see if it's helpful, but also maybe consider using a clinical trial matching service such as the one that Share offers. So clinical trials, lots of good questions being asked, lots of trials. It's a matter of matching the right patient with the right trial, for which using your own physician as a reference, as well as potentially matching services as another reference, is really important. The other thing to remember about clinical trials is you don't ever have to do a clinical trial. If you're somebody who's not comfortable with it, you don't ever have to do it. So there's no mandate to enroll in a clinical trial. If you do enroll in a clinical trial, you should know there are tremendous safety mechanisms in place to make sure that while we're answering these trials, things are kept safe. Data safety monitoring boards, institutional review boards. So these happen within a context and within a framework, and there's a large staff involved. So when you enroll on clinical trials, there are clinical trials nurses, there's the research coordinators, there's your physician, there's the PI of the trials. There's a lot of people watching and keeping mind over what's going on. So these are not done in vacuums. These are really done in highly scrutinized settings. And therefore, in a setting, you should feel very comfortable asking lots of questions. Studies are all about questions. So you as a patient should be sure that all your questions are answered when you're going on that study. Never be shy about questions in any setting. Clinical trials really also, on the broader sort of philosophical spectrum, are really a way of identifying hope in the future and drawing inspiration. Right? So they are figuring out what is the next new thing as part of the question answering process, right? We're trying to identify new therapies. We're trying to be as data-driven and scientific about it as possible. That's what helps us in our trials. And we really have all across the country some amazing researchers doing the primary bench work that enables us to then do the clinical trials. And they are a true source of inspiration and really great work. There's also a lot of inspiration around us. There are, and this whole session today is hosted in honor of Joan, a long-term survivor of ovarian cancer. There are a lot of inspirational women probably on this call, and certainly in the broader ovarian cancer community on whom to draw inspiration. There are folks that come into the media and into the news as great sources of inspiration. That lower middle picture is a YouTube video that some patients who I had the pleasure of interacting with at one of my jobs made. And when I'm having a rough day, I admit I play that video because there is more joy and energy in that video, all about today and the next day and being joyful. And so that brings inspiration. And there are a lot of books. So as you're thinking about your journey, as you're setting and charting your course, as you're thinking about your treatments and you're thinking about your broader treatment team, you're thinking about clinical trials, don't forget in all of this to make sure that on your treatment plan is your path and your process for where you're going to draw inspiration and hope when you need it. So I hope that was very helpful. I will, Maggie, do you have any questions?
Yeah, so thank you so much for that great presentation. And we have questions already coming in. So let's start the Q&A. You can still submit questions in the Q&A section at the bottom of your screen. We will try to get through all of the submitted questions, but we may not be able to due to time constraints. Okay, so let's dive right in. So this first question is about integrative medicine and sort of whether you could speak to that in terms of it being used for potentially preventing recurrence.
Yeah, I think the prevention of recurrence is such a good question. It's a little bit the holy grail. It's where all these maintenance therapies that we're working on come from, right? And there's different maintenance therapies get used. PARP inhibitors are one of those maintenance therapies. Avastin is one. Hormonal therapy is one. And very, very often patients ask, what can I do to prevent recurrence? Mm-hmm. We don't have the highest level data to answer that question. Mm-hmm. We have things that we see that help. Exercise, diet, healthy nutritionist diet, nutrition-filled diet, nothing to any extreme. Mm-hmm. Never has an extreme diet of any nature been shown to help, but healthy foods, healthy eating, some sort of a spiritual practice, whether it's yoga or prayer or whatever, has actually been shown to help also. And yes, incorporating in integrative medicine as part of your health plan can be very helpful. I wouldn't say you have to feel like you must integrate an integrative medicine specialist in order to achieve that. I think just focusing on a plan for yourself of healthy living is what will help best. And at this point, what we sort of have the best data for, meaning we have data that shows that all of these things help, but we can't make a prescription. I can't say take 2 pills a day, an apple a day will keep the doctor away. Mm-hmm. I mean, it's a nice phrase. It's not totally off because an apple is a healthy food. But there's nothing so simple as that will help. So integrative medicine physicians can be helpful in helping you chart your healthy plan if you don't feel like you're able to sort that out in consultation with your own physician. So I wouldn't say it's a bad idea, but I wouldn't say it is an absolute necessity.
Okay, great. Thank you for that. And thank you for touching on some of the other things like movement and diet as well. Okay, so the next question is, what is the likelihood of ovarian cancer returning if you don't have any of the cancer genes?
So it's a great question. The chance of the cancer returning if you don't have any cancer genes, I think probably stems from this idea that PARP inhibitors bring greater benefit to somebody who has one of the cancer genes, quote unquote. Mm-hmm. So that is true. And that modifies a little bit the answer to that question, because prior to PARP inhibitors, I think I probably would have hedged. I know I would have hedged and said, I'm not sure that that we can make that direct link, that, that there's a change in the recurrence risk. There may be a difference in time to recurrence, but the actual risk of recurrence, I'm not sure is different. And now I would say we don't exactly know the answer to that question. We are in the middle of getting that data, and we will, over the next few years, have better data on that as we understand the full impact of PARP inhibitors for folks who have a BRCA mutation. I wouldn't at this point, if you are somebody without a BRCA mutation, think in your situation that your chance of recurrence de novo because of your biology is necessarily worse. We don't know that yet. It's just that we have an intervention for the BRCA patients. So that at this point may be the difference. It's unclear.
Okay, thank you for that. And so this is sort of a several part question, but it's asking about, what you think of genomic testing, and does it aid in the ability to plan for treatment? And then if you get genomic testing, would you repeat it again if you have a recurrence?
What a great question. Okay, so fabulous question, which I'm going to try to answer quickly because I could spend a lot of time on this one. The genomic testing information can be very helpful in knowing your likelihood of responding to a PARP inhibitor. It's also, in the germline sense, critical because you need to be able to tell your family whether or not they are at increased risk and give them the information they need to prevent this from happening. And also for you in terms of breast cancer screening and other cancer screenings. So there's germline testing. What is going on in your inherited every cell of your body that every single woman with an epithelial ovarian cancer should have. Full stop. So that for your own care and for your family. So there's that piece. Now, tumor testing, beyond the germline, tumor testing can help you know how much benefit you're going to garner from a PARP inhibitor. If you're going to do a PARP inhibitor no matter what, then it doesn't change clinical management. So I wouldn't say you have to have it, but it can be helpful in understanding what your benefit is likely to be. And then the repeat testing question. This is the current sort of holy grail of where we all are looking and researching and trying to figure out, because we know that some elements of HRD, that homologous recombination deficiency, this is Liz Swisher's language, or I've heard it most commonly from her, so I'm going to attribute it to her and not take credit for it. But it's like a scar. So once it's there, it's always there. So part of what we need to figure out is, what is the next best testing after your initial therapy with PARP inhibitors? Should you be retested? But most importantly, what should you be retested for? Because it may not be HRD. It may be something like reversion mutations. It may be RAD51 foci. There's other things it may be, and that we don't yet have a good answer for. We're working on it. But it's a very insightful question, and it's our next holy grail.
Great, thank you. And so unsurprisingly, we've got in a lot of questions about PARP inhibitors, and this is specifically whether you could speak to PARP after PARP if a recurrence happens.
Yeah, so we are gathering new data about PARP after PARP. Solo 2, data came out, and that looked at sort of chemo responses after PARP. Oreo is a trial that just got verbally presented at ESMO just a few months ago. And that data was the first sort of better data we have on PARP after PARP. And there is some response and there is some benefit. It's much less than any of us wanted. And this is where those combinations come into play, because it may be that we much more need to focus on combinations as opposed to single agents. And there's a variety of combinations being studied: PARP with WEE1, PARP with CHEK1, PARP with ATR. So a variety of combinations are being investigated, but this may be where combination therapy is going to prove to be most valuable. Very new data from Oreo. We don't have the paper, we just have the oral presentation.
Mm-hmm. Great. And there are a lot of questions about PARPs, and we won't get to all of them, I don't think. So I do just want to give a plug to everyone that in September, we had a webinar with Dr. Kathleen Moore on, it was all about PARP inhibitors. So if we don't answer your question today, check that webinar out. It's on our website in case that may have answers that you're looking for.
And she's amazing. She's the great resource.
She's great.
Yeah,
Yes.
absolutely.
Okay, so now we have a question about just sort of being unclear about when to seek out a clinical trial, and sort of if you have any suggestions on how to determine if it's the right time for that.
Yeah, I meant what I said. I would say every time you change your treatment, you should raise the question. And the right time will depend on things like how you're feeling, how many sites of disease you have, what therapies you've already had, what your tumor testing shows. So there'll be a variety of factors, but I would say ask the question every time you change your regimen.
Okay, great. And so this question is, how important is sequencing of treatments, and how aggressive should we be with pursuing like treatment combinations?
So sequencing of treatments, I
guess the order of treatment.
Yeah, the order. I think that's where it's art and not science, I would say. So I think all of us have our common sequence that we use that is part of our art, and we all have anecdotal experiences that define why we use that sequence. There are drugs that we kind of commonly all tend to use earlier on: Doxil, Taxol, gemcitabine, topotecan, sort of some core ones that are probably commonalities but amongst many oncologists. But I wouldn't say the sequence is make or break.
Okay.
There's a lot of, there can be variability in that.
Okay, great. And so then this question is about, for those that are BRCA negative, and so treatments for them when they have a recurrence, and they say not often discussed, as research seems to focus on PARP inhibitors.
Yeah, so it is true. Our research focused on PARP inhibitors, but I want to say there's two elements to PARP inhibitors. There's de novo resistance to PARP inhibitors, meaning you're HR proficient, not that BRCA patient, so we don't think you're going to respond as well. So that is actually one component of PARP inhibitor resistance. And so when we talk about these combinations, we are also talking about how do we increase the utility of a PARP inhibitor for patients who don't have those genomic abnormalities within their tumor. So I think, so that is one piece of it. You're right. That is a lacking that we're all trying to work on. We do have a lot of the cytotoxic chemotherapies, the traditional chemotherapies that are effective in that setting. It's really just this one PARP inhibitor agent that falls off the list as being highly, highly efficacious. There's still some benefit in some moments, but it is true. It's not the ideal setting for it. It seems like there's such a lack, but just remember, folks, if you're 50% of women don't have that BRCA abnormality or that HRD abnormality, and so you're not alone. And we are trying to figure it out. And when we talk about PARP inhibitor resistance, we are also talking about that de novo PARP inhibitor resistance. So it's in the minds, and it's on our agenda. Okay,
thank you. And so we're running short on time, so I think we might only have a chance for one or two more questions. Try to sneak in one more. But this question is asking whether you could speak to hormonal treatment for endometrioid recurrence.
Yeah, endometrioid and low grade tend to be, low grade serous is low grade by definition. Endometrioid tend also to be grade 1 or low grade, and therefore hormonal therapy is something that we often use. So that's if that's something that's on someone's mind as a possible treatment option, it is not at all unreasonable, and it is something that gets used.
Yeah. Great. Okay, I have time for one more question.
Yeah, go for it.
Okay, so I think sort of a good place to end this on is really on this question of sort of what can people do to recognize signs of recurrence?
Yeah. So just like a diagnosis, this is such a tricky cancer, right? We all know there's these symptoms. There's symptoms that every woman has: bloating, abdominal pain, changes in your bowel function, changes in bladder function, a little bit of fatigue, a little bit of weight loss, a little bit of expansion around the waist. These subtle signs at initial diagnosis are actually the same subtle signs at recurrence. And so it is admittedly very hard for folks to recognize the symptoms, because what I don't want is folks to worry about every time they have a little GI upset, because statistically speaking, that GI upset is related to the dinner you made yourself last night and not related to your cancer. So I think the importance in this setting is to know that any symptom you have in your body should come and go. The normal things come and go. And if you have something that comes and doesn't go after 1 to 2 weeks, that's when you say, like, okay, I should probably schedule an appointment with my doctor to get it checked out. And what's hard about a cancer recurrence is it doesn't limit itself to the same body parts as your original cancer. So I always tell my patients just that general advice. Don't spend your time worrying or fretting, but if you notice that something is bothering you and it's not going away, give me a call. And I think that's the best way to handle it. So whether it's those stomach symptoms, changing your appetite, bowel function, that's going to be the most common, or something totally unrelated, like a headache that you've had that just won't quit. Subtle thing, just call. There's no harm in touching base. And worst case scenario, you say, hey, I'm worried about this. They rule out that it's anything, and then your worry goes away. So there's value in that. So, I think one thing that is true of every cancer survivor I've ever met, you guys know your bodies, and you just have to trust that. And that's really the best way to identify the symptoms of recurrence.
Great. Thank you. And yeah, just thank you, Dr. Wethington, for today's really great presentation and for answering all of these questions that were submitted. And thank you to all of you for joining us and participating in today's webinar. We ask that you please take a moment to fill out the survey at the end of the webinar. The survey will show up in the browser when the webinar ends, and a link will also be sent in a follow-up email. And please fill those out, because we really use your feedback to improve our programs. And all surveys are anonymous. So thank you again, everyone, for being here. And thank you so much, Dr. Wethington.
Absolutely. Thank you for having me. Have a good rest of your day, everybody.
You too.